Welcome back. In the last three talks, we've been building a probabilistic framework for clinical reasoning. We've talked about pretest probability, Bayesian updating, and the cognitive traps that derail good reasoning. Now, I want to step back and ask a more fundamental question. When we measure something, a blood pressure, a test result, a disease count in a herd, how do we know if that measurement is any good? The answer comes down to two properties, validity and reliability. These sound like synonyms, but they're not. They describe completely different things, and confusing them leads to real errors in how you interpret diagnostic tests, in how you read research studies, and in how you design surveillance programs. By the end of this talk, you'll be able to distinguish them clearly, explain why you can have one without the other, and apply them to clinical and epidemiological contexts. Every measurement, whether it's a lab assay, a physical exam finding, a survey question, or a count of disease cases, has to answer two fundamental questions. First, is it measuring the right thing? This is validity, also called accuracy. A valid measurement is one that actually captures the true value of what you're trying to measure. If you're trying to measure blood pressure and your cuff is the wrong size, you're not getting a valid measurement. You might be getting a number, but it doesn't represent what you think it represents. Second, does it give the same answer consistently? This is reliability, also called precision or reproducibility. A reliable measurement gives you the same result when repeated under the same conditions. A scale that gives you a different weight every time you step on it, without you actually gaining or losing weight, is unreliable. Here's the critical relationship between the two. A measurement can be reliable without being valid. Your thermometer might give you the exact same reading every time, but if it's been miscalibrated, it might consistently read 1 degree Celsius high. Highly reproducible, systematically wrong. That's reliable, but not valid. But the reverse is not true. A measurement that isn't reliable cannot be valid, because if your results are all over the place, they can't all be accurate. Some of them must be wrong by definition. The dartboard is the classic teaching analogy for this concept, and it works beautifully, so let's use it. Imagine each dart throw is one measurement. The bullseye is the true value, the thing you're actually trying to measure. Top left, darts clustered in the bullseye. This is the ideal. Your measurements are consistent and they're hitting the right target. Valid and reliable. Top right, darts clustered together but off to the side. This is the dangerous zone. Reliably wrong. Every measurement gives you the same answer, but that answer is consistently wrong. This is what systematic error looks like. The instrument is precise, it gives the same result every time, but it's miscalibrated. It misses the target by the same amount in the same direction every time. Bottom left, darts scattered around the bullseye. On average, you're in the right neighborhood, so the measurements are valid in an aggregate sense, but individually, they're all over the place. This is random error. No individual measurement is trustworthy, even though the mean might be okay. Bottom right, darts scattered everywhere and missing the bullseye. Neither valid nor reliable. This is the worst case. No useful information is being generated. The key clinical implication: systematic error is more dangerous than random error in some ways because it's invisible. If your measurements are just noisy, random error, you know they're noisy. If they're systematically biased, you may not realize it at all. You just consistently make the wrong call with great confidence. Let's make this concrete by looking at what actually causes each type of error. Systematic error, which undermines validity, comes from something consistently pulling your measurements in one direction. A thermometer that reads high every time. Using an inappropriately small blood pressure cuff on a large dog, which gives consistently elevated readings. An observer who knows what treatment a patient received and unconsciously rates their improvement more favorably. These are all sources of systematic error. The measurement is biased, it doesn't reflect truth. Random error, which undermines reliability, comes from unpredictable variation. Cortisol is a great example. It fluctuates naturally in response to stress, time of day, and handling. A single cortisol measurement is inherently noisy. Different clinicians measuring the same dog's body condition score may give slightly different scores. Different runs of the same assay may give slightly different results due to equipment variation. None of these errors go consistently in one direction. They scatter. The fixes are different for each type. Systematic error is addressed through calibration of instruments, standardization of protocols, and blinding of observers, things that eliminate the consistent directional pull. Random error is addressed by repeating measurements, using larger samples to average out the noise, and standardizing the conditions under which measurements are taken. Understanding which type of error you're dealing with matters enormously when you're reading research. A study that doesn't blind its outcome assessors has a systematic error problem. Validity is threatened. A study with a small sample size has a random error problem. Reliability and precision are threatened. These require different solutions. Let's connect these concepts directly to diagnostic test interpretation, because that's where most of you will encounter them in clinical practice. Validity in a diagnostic test corresponds to the question, does the test actually detect the thing it's supposed to detect? This maps directly onto sensitivity and specificity, which we'll cover in full in Unit 2. A test with high sensitivity and specificity is a valid test. It's measuring what it claims to measure. Reliability in a diagnostic test corresponds to reproducibility. If you run the same sample through the same test twice, do you get the same answer? A test that gives inconsistent results on repeat testing of the same sample has a reliability problem. Its results can't be trusted as individual data points. Systematic error in testing shows up when something is consistently wrong across a batch of tests, like a poorly stored reagent that consistently suppresses signal, causing the assay to read low. This is a validity problem that may not be obvious unless you're running quality controls. Random error in testing shows up as run-to-run variability. PCR results that vary between replicates, for example, due to minor variation in thermocycler temperature. This is a reliability problem that you can partially address by running samples in duplicate. There's one more important wrinkle I want to flag here, and we'll come back to it in Talk 2.4. A test that is valid in one population may not be valid in a different population. The sensitivity and specificity of a test can vary depending on the spectrum of disease severity in the population being tested. This is called spectrum bias, and it's a real-world reason why a test validated in a referral hospital population may perform differently in a general practice population. Validity and reliability aren't just for lab tests. They apply to every study you read, and the vocabulary shifts slightly in the research context in a way that's worth knowing explicitly, because these terms appear on the ACVPM exam and in journal articles. In study methodology, validity splits into two types. Internal validity asks, Did this study measure what it claimed to measure in the population it studied? Was it free of major bias and confounding? A study with poor internal validity has gotten the wrong answer for its own study population, and if it's wrong there, it's certainly not applicable elsewhere. External validity, also called generalizability, asks, do the findings of this study apply beyond the specific population studied? A beautifully designed study of hospitalized referral level dogs may have excellent internal validity, but does it apply to your general practice patients? That's an external validity question. Reliability in a study context is about reproducibility. If you repeated this study with a similar population, would you get the same result? This is affected by sample size, how carefully measurements were standardized, and whether observers were trained consistently. We'll revisit internal and external validity in detail in Unit 5 when we cover study design and evidence appraisal. For now, I want you to carry forward this foundational understanding. Validity means measuring the right thing. Reliability means measuring it consistently, and both can be threatened in both clinical tests and research studies. Here's the summary. Validity is accuracy, measuring the right thing free of systematic error. Reliability is precision, measuring consistently free of random error. You can have one without the other, but not the other way around. You can't be valid without being reliable. Systematic error pulls measurements in one direction and is fixed by calibration and standardization. Random error scatters measurements in all directions and is reduced by repetition and larger samples. Both of these concepts apply equally to diagnostic tests and to epidemiological research, which is why they appear at the very foundation of this curriculum. In the next unit, we move from this foundation into the practical mechanics of diagnostic test interpretation, starting with the most important table in all of epidemiology and the two numbers built from it, sensitivity and specificity. Pause the video, read the scenarios, and take a stab at answering them. Then we'll work through the answers together. Let's work through this carefully. This is a scenario that directly mirrors how diagnostic tests are evaluated in real laboratory validation studies. Question 1. This test is reliable, but not valid. The near identical optical density readings across 10 runs of the same sample tell us the test is highly reproducible. That's reliability. But consistently missing 30% of truly infected animal tells us the test is not accurately detecting BRSV infection. That's a validity failure. This is the dartboard scenario where darts are clustered together but off-center. Precisely, consistently wrong. Question 2, answer B, systematic error. The key word in this scenario is consistently. The test isn't randomly missing cases, it's systematically missing 30% of them. That means there is something consistently pulling the measurement in the wrong direction. Perhaps the assay's antibody threshold is set too high, or the test was developed against one viral strain and misses another. Or the assay requires a higher antibody titer than many infected animals produce early in infection. Whatever the cause, it's directional and consistent. That's systematic error, not random error. Question 3. To improve validity, you'd need to address the source of the systematic error. Possible approaches include recalibrating the cutoff value, lowering the optical density threshold for a positive call, reformulating the assay with antigens that better represent circulating strains, validating the test against a broader panel of gold standard confirmed samples, or evaluating whether the test performance varies by disease stage, since early infection might not generate sufficient antibody for detection. You might also recommend running samples in duplicate to assess reliability, but that won't fix the validity problem. It will just confirm how reliably wrong the test is. This is exactly the kind of reasoning the ACVPM exam tests, not just knowing the definitions, but applying them to a specific scenario and identifying what's broken and how to fix it.